I'm Dr. Edgar Tay from Asian Heart and Vascular Center, and today very delighted that you can join us again for this very first webinar of the Singapore ACC chapter. We had a very nice year last year with 4 webinars, and this is really our first for the year, and we're very excited. We have actually a nice plan for another 4 pretty exciting webinars lined up for you. Today, we're going to talk specifically about a very important topic called diabetic heart disease. And we have actually a very good panel of speakers and panelists that will generate a lot of discussion for this session. So before we go on further, I'll just go through some basic things. Okay, firstly, the agenda, maybe we have the agenda. Back one slide. So we'll have essentially 3 speakers, Dr. Stanley Liu, Dr. Pham Jang Min, Dr. Sheldon Lee, and then we also have Associate Professor Byung Mong, Dr. Deanna Khoo, and Dr. Kenneth who are joining us today as well. We'll introduce them in a bit more detail later. So the housekeeping slide maybe. So for those who are registered physicians, nurses, and pharmacists, you can get your continued points when you attend the entirety of the webinar. And then with the QR code, you should be able to get your certificates. And most importantly is we want to be as interactive as possible. So there's a Q&A button right at the base of your Zoom screen. So feel free to type in your questions and we will try to get them answered as we go along. Because usually try to ask them early so that you can get your questions answered. Because sometimes if you give it right at the end, we may have not much time left at the Q&A session. So let's try to get it answered as we go along. So after this, I want to just pass on the mic to Professor Po Kian Kiong. He's going to talk a little bit about ACC and some of the activities that we are planning ahead as well. So maybe I'll pass the mic to KK.
Thank you very much, Dr. Tay. When I was a medical officer choosing my subspecialty, before I became a registrar, I was choosing between diabetes or endocrine versus cardiology. And a wise old man in UK who's now director of NHS told me actually the same. So he implied really there's a great overlap between diabetes and heart. And today, thanks to BI for sponsoring this, we do have esteemed speakers and panelists, and I'm very sure you enjoy the meeting. Dr. Tay has bring the ACC Singapore chapter to distinguished level. That's the highest level within the ACC. And he's arranged for a lot of activities last year and this year as well. And this year, we do have a governor-elect coming up, which is Professor Ronald Lee, and a secretary-treasurer who is Dr. Raymond Wong, who's going to come on board the ACC Singapore chapter. So the American College of Cardiology does provide support in terms of educational support for cardiologists and trainees, right from medical students to retirement. Obviously, student memberships and those below 40 years old are complimentary, so they are free. Please join in. If you are a family physician, you can join as an international associate. But for cardiologists, you may want to try to consider applying to be a fellow of the ACC. And there is actually a calculator here where you calculate to see whether you are indeed eligible for the FACC title. So this membership does unlock access to allow communication, connection, collaboration, and also we have more than 8 JACC journals, including JACC Asia. There are also a lot of guidelines that you can access, and it allows access to exclusive webinars as well and leadership opportunity, both globally and also locally. For instance, we do have a webinar, app which you may be interested in. This is the NCD Academy. On the left upper corner, you can see the website where you can then download an app, and that actually has educational resources for not just cardiovascular disease, but also cancer, COVID, respiratory disease, diabetes, and mental health as well. So I'm really looking forward to this series of webinars, and this one in particular, diabetic heart disease. So without further ado, I'll pass back to Dr. Tay. Thank you.
Thank you, KK. So, we have many diabetic talks, but this particular session is really going to be focused really on the heart component. So this is going to be quite a unique series of talks and topics that we're going to go on. So without further ado, I'd like to introduce the very first speaker, Dr. Stanley Liu. So many of you will know him. He's a very senior clinician, more than 27 years in clinical practice. He's now a founding director of the Care Specialist Group. He's an endocrinologist expert in diabetes, and is also president of the Endocrine Metabolic Society of Singapore. And today he's going to tell us about how the cardiologist should manage the diabetics a bit better. And if we look at HbA1c, how tight should we go with the glucose control? So Stanley, please.
The slides working now?
Yes.
Okay, great. Thank you, Edgar, for the kind introduction. So I've been given this task to talk about HbA1c control. How tight should we be in patients with coronary artery disease? So when I was given the topic, so I looked at the literature, and I actually was quite stunned that we don't really have good evidence-based medicine to answer the question. So that's my disclaimer right from the beginning. So let's drill in a little bit to look at the various guidelines. What do the experts say on this matter? So ADA, the American Diabetes Association, actually would recommend HbA1c of 7%. Okay, so you can see there they also have these individualized factors. For example, looking at the risk of hypoglycemia, adverse events of the various agents used, the duration of disease, life expectancy, comorbidities, and the established vascular complications. So depending on these factors, how tight should we be, more stringent or less stringent, based on the A1C around about 7%. So that's the US, and UK, you can look, is the same. So everyone is going for 7% A1C, and that is just across the board, regardless whether we are talking about microvascular complications or macrovascular complications, including coronary artery disease. And closer to home, our local guideline also recommend A1C of 7%. And this is actually based very much on the American Diabetes Association. So where did this 7% A1C come from, you may ask? So if you look at all these guidelines, the fine print, the references, they all fall back to very much dated data. So for example, the UK PDS, the DCCT for type 1 diabetes, UGDP. UGDP, incidentally, is a very old study, started in the 60s. Results came out in the 70s and 80s using very old agents like insulin, torbutamide, and even fenformin. So, so you'll be surprised, why is everyone talking about all these very old studies? Okay, so let's analyze these studies a little bit closer. So how much evidence we have to answer these questions on A1C target and coronary artery disease. So this is the DCCT, a very well-known old study on type 1 diabetes. Obviously, the agent used was insulin because there's nothing else. And as you could see, the main positive finding was mostly on microvascular complications. And macrovascular was not significant. And the price you pay for going down to intensified intervention is the much increased rate of hypoglycemia. Okay, and then because they could not show the positive findings on the macrovascular complications, a lot of all these old studies actually extended the follow-up period to try to see whether there is this what they call metabolic imprinting or legacy effect. And as you could see, for example, this DCCT, they follow up further 10 years on. They did show that even for macrovascular complications, they were positive if you follow these patients up longer than the study period. So likewise, UKPDS, again, I think known to everyone here that it is actually the so-called gold standard study of type 2 diabetes. Again, it was a 10-year study looking at newly diagnosed type 2 diabetics, and the A1C differentiation they could achieve was very modest, only 0.9% A1C difference between intensified and the placebo arm. And again, they only could show the microvascular complications being positively reduced and not the macrovascular complications. They almost got it for the AMI, 14% reduction, but the p-value was 0.052. They just missed it by a very small margin. And I think partly because of that, we don't really have good data focusing on the A1C target for macrovascular complications. So like the DCCT, they did a longer term follow-up, and for microvascular complications, positive throughout. For AMI, for the original intention to treat arm, it was not positive, but if you follow up them longer, then it became positive. But that's not really so-called gold standard level 1 evidence-based medicine. The other point I would like to make is these were old studies, and at that time they only had insulin and sulfonylurea at their disposal. So we are talking about a very different way of treating diabetes back then. Then we had a flurry of studies, the Accord Advanced VADT. These were quite significant because they actually threw a dampener on so-called the treatment, intensive treatment of type 2 diabetes. And I'll explain a bit more. The main difference were they actually focused on people with a much longer duration of type 2 diabetes, more than a decade, as opposed to UKPDS, for example, was newly diagnosed. And as you all know, Accord was the so-called odd one out with increased mortality. Okay, let's focus a little bit about on Accord. So it's a large study with over 10,000 patients, very lofty goal of getting A1C less than 6%. And they were mostly focusing on the macrovascular complications. So so as mentioned, this is not like UKPDS. The duration of diabetes was more than 10 years, and they did almost get to that target of less than 6% A1C, but they achieve a much better difference in A1C reduction as opposed to UKPDS of only 0.9%. Okay, again, I would like to draw your attention to the fact that even a much more recent study, just over 10 years old, they were still using predominantly insulin, sulfonylurea, and at that time in vogue was TZD. So these were all the not so great agents at their disposal at that time. And the intensive arm was actually reduced, okay, not significant, but at least the trend was going the right way, lower than the placebo or standard. But what was alarming was the all-cause mortality was going the wrong way, and you could see that the intensive arm was actually having increased mortality. So which was why the study was terminated prematurely. Okay, so the non-fatal MI was trending the right way, but the cardiovascular death was going the other way, the wrong way. So because of that, the investigators actually stopped the study earlier. Okay, and again, you could see they paid a huge price on hypoglycemia, something like more than 3-fold increase in hypoglycemia, and also paid the price in terms of weight gain and fluid retention. So these were significantly increased. So hypo, weight gain, and fluid retention. Why? Because they were using insulin, sulfonylurea, and TZD. Okay, so at that time, it was thought that it's not such a great idea to aim for A1C of less than 6%. But again, I have to emphasize they were using the not so great agent 12 years ago. Okay, advanced, it was lumped together, this 3 trials. I won't go too much on it other than to say that this is a glycoside study. The only thing positive was microvascular complications. Macrovascular was not significant. And then VADT, again, it's a much older population, much longer duration of diabetes. They did have a fairly good separation of A1C. But again, this is even worse. There was no difference in cardiovascular complications, not even microvascular complications. So, so everything was so-called like a flat line, no differentiation whatsoever. So that so-called, raised a lot of questions. So why are we trying so hard in treating the glycemia, and then at the end of the day, you don't even get anything out of it. And for VADT, you don't even get microvascular complications, let alone macrovascular complications. And the idea then was that it's because, unlike UKPDS, when they treated the newly diagnosed, this one, they actually targeted the patient a bit too late at 11 years duration of diabetes. And already these people had more than 10 years bad glycemic legacy. So that was kind of like the excuse given for the failure of VADT. Partly based on these studies, the American College of Physicians actually about 2 years ago came up with a very controversial guidelines or guidance to say that perhaps we should all aim for A1C of 7 to 8% in most patients with type 2 diabetes. And maybe if once they drop below 6.5, we should de-escalate treatment, okay? And then they went on and on about, people with less life expectancy and etc. We shouldn't be so tight in the A1C targets, okay? And then, of course, they were the odd one out because the rest of the world actually advocating less than 7% still, and that still stands today, okay? So the American College of Physicians guideline was criticized, and the main thing was that they based the data on ACCORD, which I just showed earlier. ACCORD was really not representative of what we are practicing today, okay? Why? Because the agents they used were totally different. And I would say that's not the way to treat diabetes, throwing huge doses of insulin, sulfonylurea, and TZD. Okay, so I make a slight digression on the rosiglitazone saga. I'm sure all of you knew about this. Again, it's been almost 15 years. It was a blessing in disguise, although it was a very badly designed meta-analysis, but that prompted US FDA to kind of mandate the obligations on all the new drug agents, diabetes agents, requiring them to look at the CVOT, cardiovascular outcome trials, before they are considered safe in the treatment of diabetes. And the rest is history. And we at least in the diabetes world, we have many more studies to look at. Okay. So next was the DPP4 agents, Sexa, Sita, Lina, and at least they were not doing any harm, unlike, let's say, the Accord study. So it was, again, fairly neutral, no increase in cardiovascular events, with the exception of Savotini, there was increase in heart failure hospitalization. Again, it could be a red herring chance occurrence. We don't know, because the rest of the DPP4 did not have such heart failure hospitalization phenomenon. Okay, then of course come the SGLT2, and that transformed the whole scene of the diabetes treatment. Why? Because that was the first time we could actually have some claim to cardiovascular benefits in treating diabetes. But the detractor would still say that actually EMPA-REG was not really a diabetes trial. It's not a glycemic trial. Why was it so? Because if you look at it carefully, the A1C reduction, the difference with the comparator arm was only 0.45% difference in A1C. So much less differentiation than UKPDS of 0.9%. And UKPDS, despite that bigger difference in the A1C, extended over 10 years, they could still not show macrovascular complications difference. So what made this EMPA-REG different? Some would argue it's not really a glycemic trial, but more of a multifactorial trial, because this particular agent could reduce the A1C, could reduce weight loss. Weight loss was 2% in the treated arm, as opposed to the non-SGLT2 arm. And blood pressure was reduced by 5/2 millimeter mercury. So it was more like a multifactorial trial and not just a glycemic trial. And then there were lots of hypotheses why that's so, like the mild persistent hyperketonemia, few shift hypothesis, etc., etc. And it seems to be a class effect, not just empagliflozin, but you could also see a similar positive finding on the cardiovascular events in the canagliflozin. For that part, it is a slightly different population. As you can see, only 40% had cardiovascular disease, as opposed to EMPA, which was on a very high risk group with 99%. So it's actually a secondary prevention trial, and this is more of a primary prevention trial. GLP-1, another great class of agent, and again, you could see many of the agents in this class had a positive findings on MACE, for example, liraglutide, semaglutide, and dulaglutide. Locally, we don't have this albiglutide. So again, it's replicated in various other studies within the group, showing a beneficial outcome in their primary composite endpoint. Just a word of caution. So we shouldn't be rushing in and treating diabetes aggressively, because you not only pay the price in terms of hypoglycemia and weight gain for some agents, but you could also worsen certain complications, for example, like diabetes retinopathy. Okay, so this is another reminder for me to say that a quick word on what we have in terms of insulin, for example. It is not really ideal kind of insulin, because there are very subtle physiological differences. This is the so-called physiological circuitry pattern of our own endogenous insulin. But as yet, despite all the recent so-called novel insulin molecule, the designer insulin, we do not have a good insulin that we can use. And also, A1C is not a great tool in really looking at all the so-called glycemic variability, hypoglycemia, etc., etc. It's all hidden by this so-called overview of A1C. So perhaps a good way to treat diabetes is not just focusing purely on glycemia, but you also look at blood pressure, and cholesterol. Okay, so I'll end. So treating diabetes should not be, all about A1C, as I mentioned earlier. We should also consider, like, for example, like driving, the road condition, the tire condition, the age of the driver, the age of the car, and basically we're talking about personalized medicine, and look at the agents we're using. Anyone can treat diabetes well. If you hit them with, let's say, 200 units of insulin, you will get your A1C to 6%. That's no brainer. But the trick is treat it well, get to the target A1C, but without the detrimental effect of weight gain, hypoglycemia, and based on individualized risk factors. So with that, I'll end. Thank you.
Thank you, Stanley. That was excellent talk. I like your final slide. Really, I think encapsulates the concept of therapy. Because of time, we're going to move on to the next speaker. There are questions coming in, so we'll continue to stack up, and then we'll answer your questions when we get to the Q&A. So for next speaker, we have Dr. Fab Jiang Min. Jiang Min is a senior consultant at the National Heart Center. He's an expert interventional cardiologist. He does catheterization and angioplasties, and he sees, I'm sure, in his day-to-day practice, huge numbers of patients with coronary disease. And we oftentimes hear of diagnosis like, oh, this is diabetic coronary disease. So perhaps Jiang Min will share with us his experience in this topic called unique patterns of coronary disease in diabetics and how we can treat them with revascularization. Jiang Min, please.
Thank you, Dr. Tay, for the kind introduction. So good afternoon, and thanks for inviting me to talk about the coronary disease patterns and revascularization strategies in diabetic heart disease. So cardiovascular disease is a leading cause of morbidity and mortality in people with diabetes. Patients with diabetes have a higher risk of coronary artery disease, which often manifests earlier in life and confers a substantially worse prognosis. Now, diabetes is present in 25 to 30% of patients admitted with ACS and up to 40% of patients undergoing CABG. The diagram actually shows what happened in ACS in a cross-section of the left anterior descending artery of someone who needs revascularization either by PCI or requiring CABG. Now, some of the considerations and challenges in diabetes with coronary artery disease are shown here. Generally, they have more diffuse and extensive involvement. Angiograms done, such as those shown here, demonstrates that they are more likely to have multi-vessel involvement, left main disease, and complex lesions such as chronic total occlusion and bifurcation lesions. Now, this often occurs in combination with negative coronary remodeling, resulting in more diffuse disease and smaller vessels. Diabetes also have a greater plaque burden with higher calcium score and an increased number of lipid-rich plaques as shown here, which are prone to rupture. Coronary calcification, as shown here, is also a marker of atherosclerosis and a major determinant of stent expansion. Now, using intracoronary imaging, we actually can obtain more information regarding the underlying calcium involvement. Example, if the calcium is thicker, exhibits a wider arc, or affects a greater length of the vessel, it suggests a greater need for more aggressive lesion preparation. Now, the target vessel revascularization rate is higher in diabetes, partially attributed to a higher risk of in-stent restenosis and stent thrombosis as well. Now, multiple factors may be behind this, such as in-stent new atherosclerosis, poor strut coverage, or the present development of chronic inflammation causing impaired reindustrialization over time. Besides anatomical challenges, there are also systemic features as well. Diabetes causes complications affecting the entire body as shown in this central figure, and patients with diabetes undergoing revascularization, be it bypass or PCI, are at a greater risk of kidney injury. Patients with peripheral vascular or aortic disease or cerebrovascular disease are deemed to be of higher risk and are poorer surgical candidates in general. Now, such patients are more likely to be treated with PCI in current practice. The Syntax trial, which was published in 2009, was the first large randomized trial to compare treatment with PCI using first-generation DES with bypass in patients with multi-vessel disease. 1,800 patients were recruited, of which about 450 patients had diabetes. The investigators then also introduced a Syntax score to objectively evaluate in detail the complexity of underlying CAD. Now, the mortality rates and composite endpoint of death, stroke, and MI were actually similar in patients treated with either bypass or PCI at 12 months. However, as you can see from the upper right-hand panel, that major adverse cardiac and cerebrovascular events rates were actually significantly higher in the PCI group compared to the CABG group. in large part because of the increased rates of repeat revascularization, as shown in this bottom left-hand panel. Of note also that stroke was increased in CABG versus PCI at 1 year. Now, if you look at 5-year MACE rates, again, the trend of worsening MACE rates was seen, especially in the PCI group, driven mainly by repeat revascularization. Of note, in diabetics with low to intermediate coronary anatomy complexity, which was defined here as a syntax score of 32 or less, PCI actually has achieved similar outcomes to CABG in terms of the 5-year composite endpoint of death, stroke, and MI. Now, if you look at Freedom trial, which was the largest randomized control trial to date, comparing revascularization with either PCI or CABG, involving 1,900 stable patients presenting with triple vessel disease, diabetes, who were randomized in a 1-to-1 fashion to either PCI or CABG. In this study, patients with left main disease, ACS, prior PCI within 6 months or prior CABG were actually excluded. As you can see in this right-hand graph, the primary endpoint of all-cause death, non-fatal MI or stroke at 5 years occurred in 26.6% in the PCI group compared with 18.7% in the bypass group. At 5 years, the actually incidence of death as well as MI were actually higher in the PCI group compared to CABG. However, the incidence of stroke tends to be lower in the PCI group. Now, this summary table actually shows randomized control trials that involve more than 400 diabetic patients in each trial who presents with either stable multi-vessel disease or left main disease. As I presented earlier, the results of the Syntax and Cardia trial was incidentally the first randomized control trial designed to look at solely diabetic patients, suggests similar mortality at 1 year and at 5 years in both groups who underwent PCI or CABG. Similar MACE at 1 year for the Cardia trial, but Syntax actually shows increased MACE at 1 year and 5 years, with PCI driven substantially by substantially higher rates of TVR. Now, the Freedom trial shows that at 5 years, CABG is associated with better clinical endpoints, including mortality and composite all-cause death, MI, or stroke. And last but not least, we have Excel trial, which shows that potentially clinical outcomes would be similar to PCI in diabetic patients with left main disease. Now, if one look, many of the randomized control trials highlighted earlier were conducted in stable patients. Now, in this retrospective cohort study, we have about 2,900 patients who presented with ACS multi-vessel disease, revascularized either with PCI or CABG. The primary outcome measure of the study was the composite endpoint of death, MI, or stroke. Now, the benefit of bypass over PCI was actually significant already at 30 days and up to 5 years of the study period. And this is for patients who come in for ACS. And how about patients with reduced cardiac function? This is actually data from a recent observational study investigating outcomes for 1,700 diabetic patients with multi-vessel disease and LV dysfunction treated with either CABG or PCI. The primary outcome that was studied then was major adverse cardiac and cerebrovascular events. And the main finding was that CABG was actually associated with lower risk of MACE and mortality with a mean follow-up of 5.5 years. And the advantage of CABG actually being observed in patients both in a moderate impaired as well as the severely impaired cardiac function group. Now, in this observational study, they included high-risk diabetic patients with ACS, and these patients are actually defined as patients who actually presented with medically refractory myocardial ischemia, and at least one of the following: MI within 7 days, impaired cardiac function, elderly patients, or patients requiring IBP for hemodynamic support. And in this case, they note that the 5-year survival rates were actually similar among those treated with CABG and PCI. Though it's a small study, but it suggests that PCI is a relatively safe alternative to bypass for diabetic patients who are at high surgical risk for CABG. And if they look at meta-analysis, looking at diabetic patients with multi-vessel disease treated with either PCI or CABG, it also shows a difference in clinical outcomes between bypass and PCI over the years. For example, starting from 2009, with 10 randomized trials with 7,800 patients. More recently, we have data in 2013 and 2018, essentially showing that generally in the group of multi-vessel disease, mortality tends to be higher in PCI. Of note, the more recent randomized meta-analysis shows that in patients with left main disease, mortality could be similar. Now, these findings have been incorporated in the latest ACC guidelines on myocardial revascularization 2021. The guidelines state that in patients with diabetes and multi-vessel CHD, bypass is actually recommended in preference to PCI to reduce mortality and repeat revascularizations. PCI can be useful to reduce long-term ischemic outcomes in patients who are poor candidates for surgery, and that's class 2A. Now, in diabetics with left main stenosis and low or intermediate complexity CAD elsewhere, PCI may also be considered as an alternative to bypass to reduce major adverse cardiovascular outcomes. That's class 2B. Currently, there are a few revascularization strategies available. First strategy is to consider the use of intracoronary imaging, which provides critical information in procedural planning, stent deployment, and post-procedural evaluation. Operators can actually obtain precise vessel wall measurements, understand underlying plaque composition, features that may not be readily be seen on plain angiography. The use of imaging can better define plaque distribution, decide whether there's a need for more aggressive lesion preparation. It can also potentially reduce contrast use, which will lead to reduced risk of contrast-induced nephropathy. Now, beyond coronary angiograms, to determine the severity of a narrowing, FFR or fractional flow reserve can also help objectively discern whether more moderate forms of lesion narrowing require PCI. This process involves placing a wire sensor inside the coronary artery that measures the pressure before and after the lesion, which can be done with or without a need to induce coronary hyperemia. And the latest guidelines also have a class 2 recommendation for the use of intravascular imaging, for example, IVUS or OCT, in procedural guidance, particularly in cases of left main or complex coronary artery stenting. These are features that commonly occurs in diabetic patients, as I alluded to earlier, to reduce ischemic events as well as to determine the mechanism of stent failure. An example of IVUS pullback is shown here. Rather than just rely on a naked eye visual assessment, IVUS derived minimum lumen area or MLA, as seen in this central diagram, allow operators to objectively determine if a lesion in the left main, for example, is significant or not. And if within a gray zone of 4.5 to 6 mm square, one can consider use of FFR to further guide decision making. We can also use imaging to avoid troublemakers such as calcified plaque, as seen in this right-hand diagram. This will help us decide where to deploy the stent and determine the stent length and diameter. Post-procedural IVUS can detect stent-related complications such as malposition, as seen here in this left-hand panel. Operators can then decide to further optimize the result by performing post-dilatation with larger non-compliant balloons. And IVUS can also help us determine if the stent expansion is adequate using specific target areas, for example, for left main stenting. An example of OCT co-registration pullback, allowing a close correlation of angiogram images with OCT images, is also shown here. Using an algorithm called MLD, one can use OCT to strategize and optimize lesion coverage by checking morphology, identify the appropriate landing zones, which can be used to determine the exact length and diameter of stent required. Now, post-stenting, OCT can also be used to check for medial dissection, assess how well the stent expanded, and opposed to the vessel wall using this algorithm called MAX. And any significant defects can be further optimized by further post-dilatation or stenting. Now, the second strategy I'd like to share is for the use of a patient-tailored drug-eluting stent choice. The latest ACC guidelines recommend DES to be used in preference to bare metal stents to prevent restenosis, MI, or acute stent thrombosis. This applies to diabetic patients as well. Now, new generation drug-eluting stents use biocompatible alloys, which are more flexible to implant, have thinner struts, and a good expansion profile with high radial strength. Now, when it comes to dealing with complex left main or bifurcation lesions, which is commonly seen in diabetics, the stent choice is actually important and I would say critical, as the expansion capability of the stent is critical, being this fundamental feature to determine the ability to oppose the stent in a large proximal main vessel. An open cell design with thin struts allows full opening of the struts towards both branches and facilitates recrossability, potentially reducing the risk of vessel compromise. Shown here are some examples of stents with a good expansion profile that could be suitable for left main or bifurcation stenting. A useful tip is to know the stent sizes and the dimensions can be expanded to. So it's good to have a chart or table in the cath lab, such as this shown here for reference. Now, newer stents such as the Create 8 Evo stent was actually shown to have favorable outcomes in diabetic patients as well. The stent has thin struts ranging from 70 to 80 microns, depending on the size of the stent. Polymer-free might potentially be useful in diabetics, given this unique amphilimous coating, which is a combination of sirolimus or fatty acid combination, enabling a higher drug diffusion across the vessel wall. In a recent announced sugar trial, the stent actually shows a 35% relative risk reduction from the primary endpoint of target lesion failure in a group of about 500 to 600 patients diabetics randomized to the CREATE stent compared to the control stent. Now, the next strategy available is the use of advanced calcium and plug modification devices. Calcifications are extensive, make the lesion harder to treat, as a conventional balloon will often be inadequate to crack open the rock-hard calcium deposits. Now, a highly specialized technique called rotational atherectomy uses a diamond-encrusted drill bore that spins concentrically on the wire within the artery to crack the calcium. Cutting balloons also use multiple blades to anchor the device so that we can cut the underlying calcifications without balloon slippage. We're scoring balloons as well to minimize barrel trauma and avoid slippage of a conventional balloon as well when inflated over calcium or scar tissue. Now, a newer approach also involves the use of a lithotripsy balloon, which emits multiple shockwave pulses to fracture the calcium. Another strategy that one can consider is to learn to apply the appropriate interventional techniques, such as for more complex lesions, we have a reverse cut, and for more complex bifurcation lesions, we have techniques such as double kiss crush technique. Now, for all the advances in PCI, there are still differences in PCI from CABG. The treatment effects of PCI tends to be more localized, more vulnerable to stent complications, despite all the advances in stent technology. Disease progression beyond the local focally treated areas and in non-target vessels. On the other hand, bypass do provide perfusion not just beyond the initially bypassed stenosis, but also for new stenosis more proximal to the anastomosis, and thus potentially offering a more complete revascularization in the setting of diabetics with triple vessel disease. So how then to decide between bypass surgery or PCI? Clearly, there is not a one-size-that-fits-all approach when treating such complex patients. For the individual diabetic patient, multiple parameters should be taken into account for the choice of revascularization strategy, such as coronary anatomy, lesion complexity, cardiac function, previous cardiac surgery, coexisting morbidities, and finally, patient preference. So the last strategy I'd like to share is that I believe in the interim, at least, a patient-centric shared decision-making via a heart team approach should be the current standard of care. And the appropriate revascularization strategy in patients with diabetes and multi-vessel disease should be discussed by the heart team, considering the individual cardiac, extra cardiac characteristics, as well as the preferences of a well-informed patient. I just have a very quick case example I'd like to show that I encountered recently. 48-year-old gentleman, multiple risk factors, who was admitted for angina, found to have triple vessel disease, and we actually referred to the surgeon, but noted to have internal carotid artery stenosis, found to have an unacceptably high risk of cerebrovascular disease, and he went for multi-vessel PCI. So this is a baseline angiogram that shows a long diffuse LED. It's a left dominant circulation as well. You can see the diffusely diseased LED, and it actually affects the distal segments, which is a trouble for the surgeons to find a good landing zone for the Lima graph. They're very difficult to wire this LED. I think I have to use a fine cross microcatheter to provide support to wire it. And finally, we had to use a rotational atherectomy to drill the vessel at 1.25 mm size, using 150,000 rounds per minute. And a series of cutting, scoring balloons and intravascular lithotripsy is in here, the IVL, and high pressure balloons. Finally, we actually put two stents in, 3028 and 2528 stents, and post-dilated with a 3.5 and a 3.0 balloons here. And when we did the IVUS and checked, looking angiographically, it looks reasonably acceptable, but they were actually mount or post stent struts in the mid LED. And we actually further post-dilate with a NC high pressure, bigger size balloon, 4.0 balloon. These were the final results, which I think looks fairly acceptable angiographically. And we actually double checked it with IVUS, showing that the stents were actually well expanded and post. So I'd like to end here with my conclusion. So diabetes is associated with significant morbidity and mortality in ischemic heart disease. Lesions are more complex, pose more challenges with higher adverse events. Patients show superior outcomes with CABG compared to PCI. They have lower composite risk of death, MI, or stroke and death solely, although at a increased cost of mildly increased stroke risk, especially in the first 1 year. But these are patients that actually enrolled under RCT. Now, in diabetic patients with left main and multi-vessel disease of low to intermediate coronary anatomy complexity, PCI has achieved similar outcomes to bypass. And CABG actually remains currently remains the preferred method of revascularization, particularly for LAD disease and for impaired cardiac function. Now, recent advances in PCI, whether in the realm of intracoronary imaging, lesion preparation, stent design, have actually led to improvement in procedural outcomes. Whether this translates to better clinical outcomes compared to CABG remains to be further studied. The appropriate revascularization modality is best discussed using the heart team approach, taking into account the individual cardiac and extracardiac characteristics and the preferences of a well-informed patient. Ultimately, the ability to completely revascularize, weighing the short-term surgical risk with long-term benefit of reduced target vessel revascularization and mortality, as well as the patient preference, will form the basic tenets of decision-making. Thank you very much.
Thank you very much, Jiang Ming. Because of time, we're going to move on to the next speaker. That's Dr. Sheldon. Sheldon is a heart failure specialist. He's going to talk to us about how diabetes can affect the heart directly. Of course, through what you've seen, Jiang Ming's talk, coronary disease can cause heart failure, but certainly there are other mechanisms where diabetes can cause heart failure. So maybe we'll have Sheldon come on and give us his talk.
Hi, thank you very much, Dr. Tay, for the kind introduction. I'm Sheldon. I'm Dr. Sheldon Lee. I'm a senior consultant in Changi, and my area of subspecialty is actually heart failure. So I thank the ACC chapter for inviting me today to talk about heart failure in diabetic patients. So heart failure is actually a very significant problem. It's ever increasing in prevalence globally. And it has been estimated that heart failure affects more than 60 million people worldwide. And 1 in 5 of those above the age of 40 actually run the risk of developing heart failure at some point in their life. It is the top cause of hospitalizations for patients above 65, and it's associated with considerable morbidity as well as mortality, with almost 30% of patients being readmitted within 90 days of their heart failure hospitalization. This comes at a huge economic cost, and despite the availability of guideline-directed therapy for HFrEF, survival rates remain rather dismal. Diabetes, on the other hand, is also a global pandemic, and is expected to affect close to 600 million people worldwide by 2035. This is almost double from the estimated 380 million people with DM in 2013 consensus. Almost half of the world's population afflicted with diabetes actually reside in Asia, and more than 72 million of these are in Southeast Asia alone. Diabetes and heart failure are actually very closely interlinked. Diabetes is a common comorbidity in patients with heart failure, and prevalence of diabetes in heart failure patients is estimated to be around 30%. Chronic heart failure patients also have a 2.5 times higher rate of type 2 diabetes compared with those without. And almost half of these heart failure patients with type 2 diabetes actually do have PEF. Now, diabetes itself incurs almost 2 to 5-fold risk of developing heart failure in diabetics. And diabetes alone confers almost 80% greater probability of cardiovascular death and all-cause mortality in those with already established heart failure. Now, as DM is more prevalent in Asia, we've also discovered some ethnic differences amongst our own Asian heart failure patients. Now, diabetes has a threefold it's threefold more common in Southeast Asia compared to the white population cohort. And this difference was apparent in both the HFpEF and the HFrEF cohort, which is nicely shown in this study in 2017. Despite the younger age and less lower incidence of morbidity, our Asian patients were actually more strongly associated with poorer outcomes than the white patients. And these results actually underscore the importance of ethnicity-tailored aggressive strategy to prevent diabetes as well as its complications. And from this Asian heart failure registry, we found that the Asian patients with heart failure, those patients that have HFpEF and have a lean diabetic phenotype actually have the worst prognosis amongst the 5 distinct type of phenotypes that have been identified amongst our Asians. So what then is the pathophysiology behind heart failure in our diabetic patients? So it's postulated that the hyperglycemia, the insulin resistance, the hyperinsulinemia that accompanies diabetes would trigger off a whole cascade of deleterious effects that contribute to the development of heart failure in diabetics. This could be in the form of accelerated atherosclerosis leading to ischemic heart disease and ischemic cardiomyopathy, or diabetes per se could also cause myocardial disease in the absence of epicardial coronary artery disease, or what we more commonly call diabetic cardiomyopathy. This could be via the left ventricular hypertrophy caused by the insulin resistance and hyperinsulinemia, or it could be due to the myocardial fibrosis and RAS activation as a response to the hyperglycemia, or there could be maladaptive calcium hemostasis leading to fibrosis and diastolic dysfunctions. So when we talk about the therapeutic options available for patients with heart failure, we will first need to clearly define the phenotype of the patient. So heart failure can be classified into 3 distinct categories based on the latest universal definition of heart failure. Broadly, heart failure patients can be classified into patients with reduced ejection fraction, or what we call HFrEF, as patients who have HFpEF, which is the patients with preserved ejection fraction, and these patients typically have an ejection fraction of above 50%. And then we have this intermediate category between the REFs and the PEFs, which we have identified as patients with mildly reduced ejection fraction. So these are patients with LVEF of between 41 to 49% on an echo. And it is postulated that these patients actually tend to behave a little bit more similarly to the patients like with HFrEF. And so actually a lot of the therapies that are useful and indicated in HFrEF can potentially be used in the population with mildly reduced ejection fraction as well. So the 2021 Canadian and ESC guidelines both recommend treatment of HFrEF and mildly reduced ejection fraction patients with a combination of ACE inhibitors or ANI. You have beta blockers, your MRAs, as well as the SGLT2 inhibitors. So in contrast to HFrEF and mildly reduced ejection fraction heart failure, there's unfortunately no guideline-directed therapy specific for HFpEF patients. Hence, HFpEF patient therapy really mainly aims to improve symptoms and well-being and treatment of the associated comorbidities. However, we do know that recently there has been first evidence of improved outcomes in patients with HFpEF from the recently published EMPEROR-Preserve trial looking at empagliflozin in patients with HFpEF. So just to summarize, we can conclude from the latest heart failure guidelines written by the major cardiovascular societies that the management of HFrEF would now be focused on these 4 classes of foundational therapies, meaning your SGLT2s, RAS inhibition with ARNI and ACE, your MRAs, as well as your beta blockers. And every effort should be made to initiate them in a quick and safe manner. And the sooner and the more such foundational therapies we can introduce, the better the outcomes and prognosis for the patients. Since today's talk is on diabetes and heart failure, so I guess the focus of the rest of my talk will be on the more commonly used and some of the more novel therapies used in diabetes. So everyone knows metformin. Metformin has been around for the longest time. Metformin is monotherapy and first-line therapy for patients with type 2 diabetes with moderate cardiovascular risk, and is recommended for patients with heart failure if the GFR is stable and not too poor. And metformin should be stopped if the patients turn unstable and get admitted for heart failure. DPP-4s are only recommended when HbA1c targets are not met, despite therapy with SGLT2s, metformin, and maybe a GLP-1 receptor antagonist, largely due to their neutral effects on the risk for heart failure hospitalizations. And for your GLP-1 receptor antagonists, basically the trials have shown a lot of mixed data regarding CV risk reduction. And as a result of the paucity of safety data available and only modest benefit of your GLP-1s over placebo with regards to heart failure hospitalization risks, the major cardiology societies all recommend, they are unable to recommend the treatment of diabetes with GLP-1 purely to reduce heart failure risk. Okay, so focusing now on the SGLT2 inhibitors, I'd like to draw your attention to the impact of your SGLT2 inhibitors on heart failure hospitalization. So in the 4 trials with looking at type 2 diabetics, these trials largely did not have patients who had heart failure at enrollment, and treatment with the SGLT2 inhibition actually reduced the risk of heart failure hospitalizations. And in the other 3 trials, mainly your DAPA-HF, EMPEROR-Reduce, and SOLOIST trials, these are trials looking at patients with established heart failure. And it was shown that, once again, SGLT2 inhibition with this SGLT2 agents actually reduced the risk of heart failure hospitalization amongst those patients with diabetes as well as those without diabetes. And the magnitude of benefit on heart failure events across all these trials was strikingly similar. Up to a third of the patients actually there was about a 30% relative risk reduction of heart failure hospitalization. So how do SGLT2s work in reducing the risk of progression of cardiomyopathy? It's postulated, some of the mechanisms have been put forward by Dr. Milton Packer in his very elegant paper published in JACC last year. But to cut to the chase, the SGLT2s are thought to cause upregulation of sirtuin-1 and its downstream effectors. They could interfere with the sodium-hydrogen exchange in heart and kidneys, as well as reduce the mass and activity of epicardial adipose tissue. And all these ultimately results in reduction in oxidative stress and mitochondrial dysfunction, reducing cardiomyocyte injury, as well as the immune-mediated microcirculatory dysfunction and fibrosis. Now, just very quickly touch on some of the landmark trials surrounding SGLT2s in heart failure specifically. So first up, we have the landmark DAPA HF trial, which was premiered in the ESC meeting in 2019. So DAPA HF was basically a double-blind randomized controlled trial enrolling over 4,000 patients with chronic symptomatic heart failure with reduced ejection fraction. And they were split into two arms, the DAPA group versus the placebo group. The primary endpoint was a composite endpoint of cardiovascular death, heart failure hospitalization, and urgent heart failure visits. So as you can see, there was a 25% relative risk reduction of the primary endpoint. And this result was actually consistent regardless of the DM status. And during this trial period, the number of patients that would have been needed to be treated to prevent one primary event was actually 21, which is actually very low. Next up, we have the EMPEROR-Reduce trial. EMPEROR-Reduce enrolled almost 4,000 patients, once again with chronic HFrEF, and they were randomized into the empagliflozin 10 mg arm versus placebo. And similarly, empagliflozin was found to have a significant reduction in the composite endpoint of cardiovascular death or heart failure hospitalizations in adults, both with and without diabetes. And this trial also showed that treatment with empagliflozin actually slowed down the decline in the eGFR over time as well. And in terms of safety, empagliflozin actually showed no significant difference with regards to symptomatic hypotension, hypovolemia, or hypoglycemia. Of note, there was also no cases of ketoacidosis reported in this study. Now, let me draw your attention to the first clinical trial in patients with HFpEF. All right, so this is the EMPA-PRESERVE trial, and it has actually demonstrated benefits in the utility of SGLT2s in patients with HFpEF. Published in 2021, the EMPA-PRESERVE trial randomized about 6,000 patients with symptomatic heart failure with an ejection fraction of above 40%. So that means you have both your mildly reduced ejection fraction patients as well as your PEF patients in this cohort. They must have symptoms consistent with heart failure. They must have evidence of elevated biomarkers as well. And basically, the trial was a very positive trial. After a median follow-up of about 26 months, empagliflozin was actually associated with significantly lower risk of heart failure hospitalization or cardiovascular death. And this was primarily driven by fewer heart failure hospitalization events. And in this cohort, about a third of the patients actually had mildly reduced ejection fraction. And this group also was shown to have the greatest benefit in the subgroup analysis. EMPA also showed a significant reduction in recurrent heart failure hospitalizations. So now, backed by all the wealth of data from our SGLT2 trials, we now have a compelling case for the utility of SGLT2s across the entire spectrum of heart failure, from prevention in a preclinical disease to treatment for symptomatic patients to reduce both their morbidity and mortality. And with the EMPA-PRESERVE trial, we now have a major breakthrough in the management of HFpEF. And it's one which can actually improve the prognosis of patients with HFpEF. We all know that prevention is better than cure. And so in light of the compelling evidence from the SGLT2 trials, how is its utility then reflected in our guidelines for diabetes? So in the American guidelines, we do need to consider the use of SGLT2s in patients with diabetes as well as established ASCVD, history of heart failure or kidney disease. Similarly, this is also echoed in the European guidelines. The use of SGLT2s in type 2 diabetics with high risk of cardiovascular disease or already established cardiovascular disease to reduce the risk of heart failure hospitalizations. So just some of my concluding thoughts. Heart failure and diabetes are both closely interlinked. Both diseases are already global pandemics, independent of each other. And the presence of heart failure in coexistence in a single patient actually confers a much poorer prognosis for such a patient. Current guidelines support the use of conventional guideline-directed therapy for the management of diabetics with heart failure. And SGLT2 inhibitors are now regarded as cornerstone therapy for both treatment of heart failure as well as diabetes to improve both the outcomes of patients afflicted with both diseases. Thank you.
Thank you very much, Sheldon. That's a very comprehensive review of the heart failure data, especially with regards to diabetics. So, we are now past 2, and we have gone past our usual time that we have for this webinar. So what we're going to do is we have still a panel discussion and question session. So we're going to make this quite fast, and I'm going to be very kind of specific because we have a big number of GPs joining us. So I want to kind of crystallize some of the thoughts that we have, and we have very experienced clinicians on the panel list. So I'm going to ask one question with regards to the diabetes control, one question on CAD, and one question on heart failure. And I'm going to direct this to the panelists. So the first question is for Professor Byung Mong. As you know, he has led many initiatives in the national kind of push to battle diabetes, and he's working very hard on this. And so, Yongmo, I want to ask you if we as clinicians or GP doctors who see patients with, say, CAD and found to have diabetes, say a new diabetic diagnosis, what would be your first and second choice of diabetic medications that you would recommend for these patients? And perhaps what is your personal advice on HbA1c targets?
Thanks, Edgar. So to me, I think for many endocrinologists, lifestyle modification as well as first-line metformin probably will still be the cornerstone treatment. But if the patient has a pre-existing coronary artery disease, we are looking at a higher risk of population. Then the question is, what do you add on next, and when do you add on next? I think in this type of cases, we are looking for a reason that we cannot start SGLT2 or GLP-1. So these two classes of drugs are probably our preferred second-line treatment over the traditional sort of sulfonylurea or even TZD, which we are using it very sparingly now. So SGLT2 or GLP-1 receptor agonist post-metformin. In terms of the A1C target, if it is newly diagnosed, right, I think the first threshold to hit would be 7%. But you'll be surprised after patient being newly diagnosed with diabetes, most of the time there will be a drastic lifestyle change. So I think if they can hit A1C down to below 6.5% or even closer to 6%, usually we don't back off very, very upfront. So I think the lower the better without any side effect, particularly hypoglycemia. So at the start, you do see this rather sort of a quick decline in the HbA1c. Then the challenge to the practicing GP would be how do you maintain at that level, because the usual 90 curve will come after that, or the A1c will slowly creep back up after 12 months. So that is my preferred strategy now. Sulfonylurea, acarbose, all these have been pushed probably to the third line, even the fourth line of the treatment regimen. Yeah.
Thank you very much, Yongmong. So next we'll have Deanna. Deanna is an interventional cardiologist. She too, like Jiangmin, sees a lot of patients with diabetes, and every day in the cath lab, I'm sure she has to make a decision after the angiogram whether the patients need to go for PCI, meaning putting in stents, or do a bypass operation. So, GPs usually are very important partners with us, and they actually see the patients for many years. They know them very well. They know their preference. And what, in your kind of view, Diana, is the best way a GP can help to guide their patients? If, for example, a patient comes to them with angina and they have been told that they need revascularization, what are the top 3 factors that you think would be most important for them to guide these patients to go to surgery or intervention?
Thanks very much, Edgar. So as Ming Xiang had very excellently demonstrated in his talk, the first thing we look at is the extent of coronary artery disease in patients. So in diabetics who have multi-vessel disease, where the disease is quite complex with what we call a high syntax score, as well as patients in whom they have left ventricular dysfunction. These groups of patients generally would benefit more from CABG over PCI. Number 2 is a lot of patients with diabetes. As we know, they are quite a complex group of patients, and a lot of them have a lot of comorbidities. So patients with sort of comorbidities with things like end-stage renal failure, CKD, a lot of them are excluded from these trials. So we also have to look at what comorbidities they have, the age of the patient, and decide if they are at a higher surgical risk, in which case sometimes bypass may not be such an appropriate option for them, and PCI might be better for these patients. And then I think lastly, GPs know their patients often a lot better than we might do when we have limited contact with them, and patients' beliefs and what their wishes are in terms of whether they're prepared to even go through bypass surgery is quite important. So they might have a little bit more time to discuss these options with the patients. Sometimes patients, even if bypass is a better option for them in terms of reduction in mortality or reduction in revascularization, bypass is just not an option for them at all. So I think the conversation that GPs can help to have with these patients are very important.
Thank you, Diana. That really kind of summarizes as well some of the kind of day-to-day questions that patients ask us. And even though we tell them that bypass is the best options, some of them do choose less invasive options. So we'll move on to Kenneth next. Kenneth, as you know, he's a very experienced heart failure specialist. He's with the Novena Heart Center Group, and he's treated many patients with all the way from very early diagnosis of heart failure to very advanced heart failure therapies. And Kenneth, so we want to just guide our family physician colleagues as well. And if, say, a patients who come in with NYHA2, perhaps a newly diagnosed heart failure patient and found to have diabetes, and we know that earlier on, Sheldon shared with us the pillars of heart failure. How is there a specific sequence in this form of pillar that you would choose, or would you put a small dose of everything and throw it all at them at one go, or would you try to titrate in sequence? And what would be your strategy?
Yeah, that's a very, very good question. As you know, both ACC and ESC has algorithms in terms of the flow of drugs. I guess when we had no treatment options, it was quite easy to decide what drug you want to give. But now we have so many treatment options, and if you have a newly diagnosed heart failure patient with diabetes, I think you are really spot for choice on what you would like to start the patient on. I think the most important is I would look at the drugs that would actually have very strong cardiovascular mortality reductions. So usually that would be the beta blockers and the ARNI, which have shown to reduce death significantly. And probably I would use both as starting at a low dose and starting it together. I think we always have a lot of things to watch out for when we start all these medications. And I think primarily the main issue is blood pressure and the heart rate. So if your blood pressure is not very high to begin with, then you're always worried about adding too many things all at one time, and it may cause significant hypotension and problems to the patient. The other thing also, of course, is to also have know what the baseline kidney function is, because a lot of therapies do affect the kidneys. So we have to be very careful as well, because we may cause a rise in the creatinine once we start the medications. I think now after the ARNI and the beta blocker, I would definitely choose SGLT2 as the next drug to add on, because I guess one thing about SGLT2 is that its main benefit is actually reducing heart failure hospitalizations and time to first heart failure hospitalization. The reduction in mortality is a little bit more iffy. So, and it seems to have a little bit of a diuretic effect also. So I guess in patients with milder forms of heart failure, I think adding on SGLT2 is quite good, because then you may not need to give a diuretic together with the medications. I think subsequently, if let's say you have more information available, it's quite tough for GPs, I guess, because you may not have echo easily. But let's say if the EF is still very poor, let's say below 30%, then I think adding on spironolactone would probably be a very cheap and good option after the SGLT2 inhibitor. Of course, having all these drugs added together, the other thing is, of course, cost is always an issue. So because the burden of cost, I mean, all these are relatively new drugs, especially ARNI and SGLT2, they can impose a huge financial burden on the patient. So I guess some people actually do suggest giving SGLT2 first instead of ARNI, because it's cheaper. And then maybe once the SGLT2 is added on, then later on to add on the ARNI. So that could be a possibility as well, if you want to look at it in the more financially kind of money saving kind of approach. I think ultimately the goal is to get all the 4 classes of drugs onto the patient as soon as possible, as fast as possible. So don't forget to up titrate the medications as well, because a lot of times we find patients are stuck on basically very low doses of all the different drugs. And we know that we have to achieve the target doses to get the kind of benefits that we see in the clinical trials. So we should try to titrate the medications up one by one, maybe every 2 weeks or every month, so that we can rapidly get the kind of benefits to the patients on board as fast as possible. Thank you.
Thank you, Kenneth. There's actually a question that I think is quite important. That was asked, actually quite similar to another question. Oh, Kenneth put up this question as well with regards to someone with concerns about creatinine levels above 200. So maybe I'll direct this our last question to either maybe Stanley and then Yong Mong can give their insights into this situation where nowadays more people are prescribing SGLT2 inhibitors for heart failure patients, and also for other new indications like CKD as well. And various trials take various EGFR kind of cutoffs for their inclusion criteria. So is there an easy way for clinicians to remember, like, what are is there any EGFRs that we have to be concerned about, and can we just kind of not look at these numbers and just initiate the drug? So maybe we'll have one comment from Stanley, and then maybe we'll have the ending comment from Yong Mong. Stanley, you're on mute. Stanley.
Sorry. So we usually go by eGFR, as you mentioned, and if you follow the so-called HSA or the drug regulatory bodies, usually they use the cutoff of GFR of 30. So, but having said that, you know, a lot of us use it off-label. For example, you know, we know the effect. It has a renal protective effect. So it kind of counterintuitive if you stop it, you know, just because you want to follow the recommendation that if it's less than GFR less than 30, you perhaps would want to stop it. Yomo?
Yeah, so indeed, if you base it strictly on local HSA approved indications, it's creating quite a bit of confusion. So among the 3 public health clusters, we are actively trying to put up a clinical sort of a guidance. So for simplicity, if you are looking at pure glycemic plate, that means you are aiming to treat the glycemia, then the cutoff across the 3 SGLT2s would still be 45 if you play it that way. But the problem is when you move on to treatment-based indication, say for CKD and heart failure, for the dapagliflozin, the local labeling has allowed initiation when eGFR is above 25. Whereas for the empagliflozin, HFrEF indication, the cutoff is above 20. For the canagliflozin renal indication, the cutoff is above 30 and it's only restricted to 100 milligrams. So you can realize the confusion at the ground. Fortunately for the public hospital, we only have 2 SGLT2s. But I think in the private sector, you really need to know the sort of the local indication. But if it's pure glycemic plate, it's 45. Once you go into heart failure and CKD, it's either 20, 25, or 30. But these are very sort of narrow margin, like Stanley say, sometimes there will be off-label use. Yeah.
Okay, thank you very much. Because we've really run over time by quite a bit. So I want to just thank everyone for joining us, especially our speakers who have spent much time preparing these very interesting topics today. And also for our panelists for giving us their insights into this, this condition of the complex condition of diabetic heart disease. And of course, all of you who spent the last 1 hour with us. So please, if you have time, please use this QR code, give us some feedback so we can improve on our sessions. And with that, I would like to thank you all again and have an excellent Saturday and Sunday. Thank you very much for joining us.